In this lecture video, I will discuss about toxic and metabolic disorders, its radiological findings. We will discuss firstly the gray matter involvements, which include Wernicke's encephalopathy, then Toledan encephalopathy, then carbon monoxide poisoning, methanol poisoning, uremic encephalopathy, hepatocellular degenerations, diabetic stereopathy, and metronidazole encephalopathies. In these cases, deep gray matter involvements occur in the brain. Then what are the pattern, how they are involved, we will discuss in detail. In Wernicke encephalopathy, the presentation of the patient is confusion, ataxia, and ophthalmoplegia. These are the classical triads of Wernicke's encephalopathy. It is because of thiamine deficiency, mainly seen in alcoholics. And in these cases, there is involvement of medial thalamus, mammillary bodies, and periaqueductal and periventricular gray matters. Here we can see the involvement of the thalamus as well as mammillary bodies and periaqueductal gray matter involvements, which are characteristically seen with Wernicke's encephalopathy. These are bilateral symmetrical involvement of the thalamus, mammillary bodies, and periaqueductal gray matters, which is seen in thiamine deficiencies, and these patients present with confusion, ataxia, and ophthalmoplegia at the triads. Then in toluene or solvents, that is encephalopathies, the presentation is the movement disorders, cognitive impairments, and it is because of chronic inhalant and abuse. In these cases, thalamus, globus pallidus, substantia nigra, and periventricular white matters are involved. In these cases, T2 image shows hypointensities, and white matters are T2 hyperintense. Here we can see in T2 image, these lesions are hypointense and white matters are hyperintense. Which is seen with toluene encephalopathies. These are characteristically seen with toluene ingestions. These patients present with movement disorders because of the involvement of substantia nigra and cognitive impairments. Then carbon monoxide poisoning. The presentation of the patient is headache, dizziness, altered mental status, and seizures. It occurs because of fire-related smoke inhalations or poorly functioning heating systems or improper ventilated fuel burning devices or vehicles. In these cases, carbon monoxide is produced, leading to if the person get exposed to these smokes, then carbon monoxide poisoning can occur, and if the brain is involved, it can lead to the globus pallidus, and the white matters are characteristically involved, which can be seen in T2 and FLAIR hyperintensities. Here white matter is involved along with the globus pallidus involvement, which is characteristically seen with carbon monoxide poisoning. Then methanol poisoning. These patients present with visual impairments, headache, nausea, vomiting, coma, and unhand gap metabolic acidosis, when you do ABG. On performing an ABG analysis, you can get an anion gap metabolic acidosis. Etiology for it include ingestion of antifreeze cleaners that can lead to methanol poisoning. In these cases, putamen, optic nerves and subcortical white matters are involved, and in this shows hyperintensity in T2 and flares. Thus, these putamens, optic nerves and subcortical white matters involvement is seen with methanol poisoning. Then uremic encephalopathies. These patients present with altered mental status, diffused weakness, tremors, myoclonus, ataraxis and seizures. It occurs because of acute and chronic renal failure. The presentation of it is the involvement of basal ganglions as well as cortical and subcortical white matters. Thus, they show hyperintensities in T2 and flares. It is called as lentiform Fock sign. In these cases, white matters hyperintensity outlining the hyperintense lentiform nucleus described in metabolic acidosis of different causes. That is called as lentiform Fock sign. In these cases, we can see the white matter hyperintensities outlining the hyperintensities of the lentiform nucleus, leading to lentiform Fock sign, which is seen with uremic encephalopathies and other causes of metabolic acidosis. Then, acquired hepatocellular degenerations. The presentation of it is movement disorders, cognitive impairment. It occurs in the patient with cirrhosis with manganese overdose. In these cases, globus pallidus shows T1 hyperintensities, and it occurs in the patients with total parenteral nutrition or bilirubin encephalopathies, that is called cardiac. In these cases, globus pallidus shows T1 hyperintensities in the patients with acquired hepatocellular degenerations, and it occurs with manganese overdose. Then diabetic stereopathies. The presentation of it is hemichoria and hemibalismus. It occurs because of hyperosmolar, hyperglycemic, non-ketotic states. In these cases, there is unilateral involvement of putamens, caudate nucleus and globus pallidus. This shows T1 hyperintensities and T2 hypointensities. In these cases, diabetic stereopathies, there is unilateral involvement of caudate, globus pallidus and putamen. Then, artery of Percheron infarcts. These patients present with altered mental status, vertical gaze palsy and memory impairments. Etiology include occlusions of rare variants of small branch of P1 of posterior cerebral artery that supplies bilateral thalamus, leading to artery of Percheron infarcts. In these cases, paramedian thalamus and rostral midbrain involvements occur. Thus, this shows T2 and FLAIR hyperintensities of the paramedian thalamus nucleus, leading to arteries of Percheron infarcts. It is also a gray matter involvements of the brain. Then, bilateral thalamic lesions, that is deep cerebral venous thrombosis, will lead to bilateral thalamic infarcts, which can be seen with FLAIR, and diffusion restrictions can also be seen. In these cases, bilateral thalamic lesions can be seen. Then bilateral thalamic lesions can also be seen with flavivirus encephalitis. Here we can see the bilateral thalamic involvements in FLAIR, and there is diffusion restrictions. Apart from it, diffused glioma can also cause bilateral thalamic lesions, which can be seen in the FLAIR and diffusion. Then cortical pattern of involvements, which is seen with opioid associated amnestic syndromes, acute hepatic encephalopathy, and hypoglycemic encephalopathy. In these cases, cortical involvements occur. In opioid associated amnestic syndrome, amnesia is more than of 24 hours, and it is because of opioid uses. Example, fentanyl. In these cases, hippocampal as well as cerebellum or basal ganglionic involvements can occur, which can be seen in T2 and FLAIR hyperintensities. Thus, cerebral, hippocampal and basal nuclei are transiently shows edema with restriction diffusions, seen with opioid associated amnestic syndrome. Then hepatic encephalopathy, that is hyperammonemic ammonia associated encephalopathies. In these cases, patient shows cognitive deficits, lethargy, ataraxis, and etiology include liver failures or portosystemic stenting. In these cases, insula, cingulate gyrus, thalamus, posterior limb of the internal capsule, dorsal brain stem and diffused cortical involvements occur. These are the presentations of hepatic encephalopathy with hyperammonemia, with increased serum ammonia level. Then hypoglycemic encephalopathies, these patients present with seizures, reduced conscious level. Etiology include hypoglycemia like diabetic medications, overdose. These patients will present with cerebral cortical involvements, that is cortical involvements occur, mainly the posterior part with hippocampus, basal ganglions and white matters. Especially the posterior limb of the internal capsules are involved in the patients with hypoglycemic encephalopathies. DD include hypoxic or ischemic brain injuries, hepatic encephalopathies, seizure-related changes or CJD. In these cases also the cortical involvements occur, that can be a DD with the hypoglycemic encephalopathies, that is hypoxic ischemic brain injuries, hepatic encephalopathies, hypoglycemic encephalopathies, CJD, seizure-related changes. These all can be DDs in which cortical involvements occur. Then hypoxia or ischemia-related encephalopathies. The presentation is usually the patient is in coma state, mainly occurs because of cardiac arrest with prolonged CPR. In these cases, cerebral cortex are diffusely involved, deep gray matters, basal ganglions and thalamic involvement, cerebellum and white matters involvements can occur, which can be seen in T2 and FLAIR hyperintensities with swelling as well as diffusion restrictions. There can be pseudo-normalization by a week. Then white matter, these were the gray matters involvements with the cortical or deep gray matters. Then the white matters can also be involved in toxic and metabolic encephalopathies, which can be seen with acute toxic leukoencephalopathies, chasing the dragon leukoencephalopathies, osmotic demyelination syndrome, posterior reversible encephalopathy syndrome, that is PRESH, or cytotoxic lesions of corpus callosum or Marki-Fava bignami disease. In these cases, white matter involvement occur. Earlier, we have seen the gray matter involvement, whether it deep or the superficial. Then the white matters involvement. The first one is acute toxic leukoencephalopathies. The presentation varies from inattention to coma. It usually occurs with chemotherapies like various medications for the cancer treatment, immunosuppressive medications, opioids, hepatic encephalopathies, carbon monoxide poisoning, or uremia. In these cases, there is diffused white matter involvements in the periventricular areas. Thus, periventricular white matter involvement which shows T2 and FLAIR hyperintensities, which can be seen with acute toxic leukoencephalopathies. Then, chasing the dragon leukoencephalopathies, these patients present with ataxia, dysarthria, mutism, and paresis. Etiology include heparin, heroin, and vapors ingestions. In these cases, chasing the dragon leukoencephalopathies, this presentation can be seen with involvement of cerebellum, and with butterfly wing-like distributions, posterior cerebral white matters involvement, or posterior limb of the internal capsules involvements, this posterior cerebral white matters involvement, which can be seen with in the T2 and FLAIR images, which shows hyperintensities. This corticospinal tract involvement occur. Then we have the posterior reversible encephalopathy syndrome. The presentation of it is headache, decreased conscious level, visual disturbance, or seizure. Etiology include hypertensive crisis, hypertensive emergencies in prolonged hypertension states, immunosuppressive medications, and renal diseases. In these cases, subcortical and cortical perito-occipital dominated white matter involvements occur. Here we can see the perito-occipital involvements, cortical and subcortical patterns with peri-superior frontal sulcus, holohemispheric watershed lesions, cerebellar involvements, brainstem and deep gray matter nuclei can be involved. Thus, this shows T2 and FLAIR hyperintensities. Thus, posterior reversible encephalopathy syndrome. These patients present with seizure, decreased conscious level, visual disturbances, and seizures, and etiology being hypertension, prolonged hypertension, immunosuppressive medications, and renal diseases, and the pattern of involvement is cortical and subcortical perito-occipital regions. Then osmotic demyelination syndrome. The presentation include encephalopathy, paresis, seizures, and ataxia, as well as coma. Etiology include rapid corrections of hyponatremia, as in case of alcoholics. The involvements include pontine, involvements being the common, as well as thalamus, basal ganglions can be involved, that is extra pontine involvement. Because of the pontine involvements, we can get trident and piglets, and which is the central pontine hyperintensities, sparing the corticospinal tracts. In these cases, osmotic demyelination syndrome can present with trident and piglet signs. Then cytotoxic lesions of corpus callosum, the presentation being incidentally diagnosed because of various pathological causes, and etiology being anti-epileptic drugs use and withdrawals, but also can be seen with toxic and metabolic disorders, viral infections and subarachnoid hemorrhages. In these cases, cytotoxic lesions of corpus callosum can occur. Here we can see the involvement of corpus callosum, splenium, usually in the midline, extensive to anteriorly with diffusion restriction and T2 and FLAIR hyperintensities. Thus, cytotoxic lesions of corpus callosum can occur with viral infections, toxic and metabolic disorders, with the splenium of the corpus callosum being involved. Then, Marki-Faba Bignami disease. These patients present with neuropsychiatric disorders, dysarthria, ataxia, seizures or coma. It mainly occurs with alcoholics. In these cases, xenium, body and splenium of the corpus callosum is involved, with the middle layers is most commonly involved, leading to sandwich sign, which can be seen with T2 and FLAIR hyperintensity. Xenium, body and splenium of the corpus callosum being involved. Then metronidazole encephalopathies. These patients present with cerebellar dysfunctions, confusions and seizures. It can occur with metronidazole therapy. In these cases, dentate nucleus of the cerebellum, dorsal brain stems and splenium of the corpus callosum can be involved, which can be seen as hyperintensities in T2 and FLAIR. DDs include isoniazide toxicities and Wernicke's encephalopathies. In these cases, cerebellar involvements can be seen. Thus, metronidazole encephalopathies will present with the involvement of dentate nucleus of the cerebellum being involved, thus leading to cerebellar dysfunctions. Then progressive multifocal leukoencephalopathies. The presentation include altered mental status, various neurological deficits. It can occur with JC virus infections, usually in AIDS or HIV patients. In these cases, multifocal, asymmetrical, periventricular and subcortical white matters, including the U fibers, periventricular and subcortical white matters involvement, as hyperintensities in T2 and FLAIRs, which can be seen with JC virus infections, usually with AIDS and HIV. This patient will present with altered mental status with the involvements of periventricular and subcortical white matters, including the U fibers. Then diffused white matters involvements, which can be seen with HIV encephalopathies and acute disseminated encephalomyelitis, ADEMS. In these cases, diffused white matters involvements occur. Here we can see the white matters involvement in a diffused pattern as well as in ADEMS. This diffused white matters involvement. Then it can be also be seen with Rist-Wenger's disease, that is all called as subcortical arteriosclerotic encephalopathies. In these cases also, diffused white matters involvements occur, as well as in CADASILs. Here we can also see the diffused white matters involvement. It can be seen with vanishing white matters disease with the diffused white matters in pattern of involvements and metachromatic leukodystrophies. These patients will also present with white matters, diffused white matters involvement. So, the different causes of diffused white matters involvements include HIV encephalopathies, ADEMS, acute disseminated encephalomyelitis, subcortical arteriosclerotic encephalopathies, that is Rispranger's disease and CADASIL's, then vanishing white matters disease and metachromatic leukodystrophy. So this was all about the radiological findings in toxic and metabolic disorders of the central nervous system. Thank you all for watching my lectures. Do subscribe to my channel for more and regular updates on interesting topics of the medical science.